Good day to you all. Good day to you all. I do hope that I am audible and everyone can hear me. My name is Anna Sango and I work for the global network of people living with HIV. And I'm super excited that all my time to be available for this great webinar that we are going to be having this afternoon, probably morning, depending on where it's from. And we're super excited to be talking about children and better treatment options for children with you today. Big thank you to the team behind the scene. Okay, so I'm noting that there's a bit of background noise from my end. Apologies. Let me try and make myself secure in a more quieter place. Okay. So I will try to raise my voice louder so that we can be able to hear them. So let me just quickly run through housekeeping first. Please note that the webinar will have interpretation in French and in Portuguese. And then please feel free to utilize the chat function to tell us where you're joining us from, as well as to post your different questions there. And then with the panel of experts that we have, you'll be able to get access to some of the answers. And then also, the meeting is recorded for the purposes of follow-up and feedback. And just to note that the issue with the French translation has been addressed. So in terms of the webinar, why a webinar on better meds for kids, and also why this work is important to us. So as the global network of people living with HIV and as partner, and also including the GAPA family, we do acknowledge that while closing gaps for access to safe and more optimal treatment options for children, the new PALT dispersible tablet has been introduced, and this is a triple fixed dose combination that includes dolutegravir and comprises a complete regimen in one convenient pill. This formulation, sorry, apologies, my camera was off. Apologies, everyone. Hello, here I am. So this formulation aims to simplify treatment by replacing the need for separate tablets in children's treatment. So with this webinar, we're bringing together experts to discuss this updates on HIV treatment for children and actions that communities and networks can take to promote access and treatment literacy, whilst discussing ongoing barriers to optimal and affordable HIV treatment for all children. And this is work that we are particularly keen on and invested in as GMP Plus, as well as PARTA, and through our work as well around ending pediatric AIDS in children, and also within our collaborative work within the Global Alliance to End AIDS by 2030. So without further ado, I will go on and introduce the speakers that we have for you today. So apologies for that. So I will go on and introduce the speakers that we have for you today. So first off, we are going to have Dr. Abdullah Ibrahim, who is the Principal Medical Officer at the Government House Clinic at Mata, and then also Health Advisory member as well as a global athletes champion from Nigeria. So Dr. Abraham is responsible for overseeing all clinical and administrative activities of the hospital, as well as ensuring that all people who visit the facility access athletics and lead healthy lives as a certified medical doctor. He has also undergone rigorous training and experience in clinical practice. So I'd just like to move the floor over to Dr. Abdullah Ibrahim just to speak to us. Over to you.
Thank you, Anna. Thank you, Anna. Thank you so much. And just to add that I'm also a Global Alliance champion for children living with HIV, representing Nigeria. So I will just take this time to talk to us about the challenges that we face in the treatment and care for children and adolescents living with HIV. Just to give us a perspective of the discussion, I would like to start by saying that categorize this discussion into three. First of all, we want to look at these challenges from the perspective of preconception, and then we'll look at the children in utero, and then look at the children post-delivery. So preconception, just imagine in Africa where all the women of reproductive age, they know their status, and those who are diagnosed, 95% of them know their status, and those who are diagnosed, and 95% of them are enrolled into treatment, and then 95% of them are suppressed. That will mean that every child coming from such women, the likelihood of them being positive is very, very low. So that is the first place to look at when we look at the challenges we encounter in managing children from that aspect. The second part is about looking at it from the child in the womb, the pregnant woman. One of the challenges we face with that aspect is the fact that is the availability of PMTCT services. That has to do with testing during pregnancy, education of pregnant women, and then retesting in pregnancy to ensure that those who are positive are enrolled into care, they get ART on time. And so we have challenge with that because we have up till now in Africa, especially in Nigeria, the coverage, especially in our antenatal clinics, is still very, very low. It's still very, very low, you know. And so that is a big hindrance for the challenge in managing children living with HIV. And then another thing in that same regards is the fact that sometimes we test the pregnant women who come, and then there's no retesting of them even during their antenatal clinic visits. So somebody was negative before is missed because she was tested once. So, and then having them coming down with a child who is already exposed to HIV. Now, looking at it from the post-delivery, the first challenge that we have in the treatment of children and adolescents living with HIV is the fact that finding a child with HIV is quite difficult. It's quite difficult to find a child with HIV. In fact, you will have to do about 100 to 200 HIV tests for you to be able to get one child who is positive with HIV. That tells you how we needed to be very strategic and precise in order to get a single child living with HIV. So secondly, on that same this thing, we now look at availability of what we call early infant diagnostic services. Currently, the coverage for availability for such testing is quite low. Most of our primary care centers where these children are born, you know, our health facilities, we do not have these services. Some of these women, they live in hard to reach, the mother and the child live in hard to reach areas. So for them to be able to access these EID services is quite difficult for them, and that provides a kind of challenge in treating them. So apart from that, we also have the fact that the availability of ARVs for children is not just the availability alone. We have, if the drugs are even available, some of these children, especially weight, at the early stage, we have what we call the weight-based, give ARV based on their weight. So some of our clinics, some of our hospitals, we don't even have these weighing scales, So that provides a kind of challenge for managing and treating these children, and also even when sometimes these ARVs are not even available. They are not available at all. And then even the knowledge on how to the kind of pediatric dosing and meet the healthcare workers is even lacking. So there's need for appropriate training in that regards. And also, looking at the child, one of the disadvantages of the child is that the child is dependent. The child needs the parent to come to the parent or the caregiver to come to hospital, the parent or the caregiver to come to viral and things like that. So because they are very dependent, a lot about their care is tied to their caregivers. So if the caregivers is not serious, is not willing to come to facility and things like that, we have that challenge. Another thing is that most caregivers and parents, they look at the possibility, look at this child is positive, what is the prospect of this child, and the stigma around having a child that is positive. That also contributes to whether that child is sustained in care over time. So we have a lot of children who are enrolled into care, but over time they are not sustained. That poses a challenge. And also there's disclosure status. A lot of parents caregivers do not want the child to be disclosed to because of the stigma, the fear of what people will say out there concerning them. So they want to try to keep these children so that they will not be aware of their status. So that poses a lot of challenge, because if a child who ought to have full disclosure of his or her status is not disclosed to, that child will not take responsibility over their health. So in a summary way, I would say that in all the challenges we are faced, the single most challenge that we have is identifying these children. So efforts have to be made in our antenatal clinics, in our immunization clinics, even in the adult clinics, the pediatric wards, all that. And unfortunately, most of our health system, or each of our hospitals are designed with the adult in mind. They are not designed with the child in mind. So it makes it difficult for child-specific services, child-friendly services, kids club, and to be provided for such children. So if that's some of the challenges we face, if these things are looked upon, I believe that we will be able to handle the issue of challenges with care and treatment for children. So thank you so much, Anna. Thank you so much.
Great. Thank you. Thank you so much, Dr. Abdul, for sharing some of those interesting insights, and also some of the key challenges that are happening in terms of your country context as well as at the facility, and also really highlighting how some challenges and issues are there when it comes to SHA, and how that also impacts the health and well-being of the child when they are taking their treatment as well. That's very important to note as well. And also highlighting some of the challenges around stigma and discrimination that a child can face, or that the parent can face, that can also contribute to the challenges in terms of being able to access treatment. And also acknowledging that with the work that you're doing in terms of setting up the Kids Club and also a Caregivers Forum, being able to also create a platform with different individuals and different parties can be able to discuss some of those challenges. Thank you, and we'll get back to you during the question and answer. So again, please feel free to post your questions or comments through the Q&A. So that we can be able to get as much information as we can as pertaining to the topic. So for our next speaker, I'm going to welcome Dr. Nandita Sugadi, who is a consultant with WHO and chair of the technical advisory panel for PATA and was based in the US. Dr. Nandita is a dedicated pediatrician with a distinguished career in HIV care and treatment programs. She has made significant contributions on the front lines of the pediatric HIV epidemic in Eswatini, Botswana, Tanzania, and her home city, which is New York. Dr. Nandita's extensive experience includes working with different organizations such as BELA, the International Pediatric AIDS Initiative, the Clinton Health Access Initiative, and also ICAP at Columbia University. She's currently working with WHO as a pediatric consultant to the Department of HIV, Hepatitis, and STIs, and maintains a very strong partnership with PATA as the chair of the technical advisory panel for the organization. Dr. Nandita, you're welcome.
Anna, thank you so much for that really kind introduction, and I thank you all for being here. And to PATA and GNP Plus for inviting me to share sort of an understanding of PALD, which is the new formulation for pediatric ARVs that we are now discussing. Next slide, please. Next. And so this is a quick overview of my talk. I just want to share a little bit and just go down sort of memory lane about thinking about how treatment has changed over time. For some of us, this is new. For some of us, we have been living through this for the last few decades. And so there really has been a lot of changes, which I think it's important to keep in perspective. And when we talk about pediatric ARVs, as Dr. Abdul mentioned, we have fewer and fewer children. But we have to think about sustainable access to pediatric drugs. And the reason for that is we know that there's still children, even if they're hard to find, there's still children that need treatment. So currently what we're saying is the optimized treatment or optimized formulation for children living with HIV is what we call pediatric ALD, which is a combination of abacavir, lamivudine, and dolutegravir. Next, please. And so I want to start out by just reminding everyone that we actually have been doing very well with ART. And over the last several years, we've saved almost over 20 million lives. And this includes pediatrics. Next slide. And so you can see here in the late 90s and early 2000s, there was sort of a remarkable progress in terms of figuring out how we can treat children living with HIV. And that was the development of new drugs and formulations that children could take. And we would have studies showing that it's safe and effective to use in children. So about that time is when we started using what we started to call HART, or highly active antiretroviral therapy. And that was a combination of 3 drugs, which we knew was effective in bringing reducing the viral load. Next, please. And so this is how we started thinking about antiretroviral regimens or treatment, but it's really made up of different classes of drugs. And so for a long time, we used nucleoside reverse transcriptase inhibitors, or NRTIs, and these are the drugs like zidovudine or AZT, lamivudine 3-TC, or tenofovir, and it also includes abacavir, which for a very long time was too expensive to use in children, and as a result, we often use drugs like zidovudine or AZT, or stavudine, which we have now phased out of use. And so NRTIs, we usually call that the NRTI backbone because it's one of those drugs from the NRTI class. And usually the second drug is lamivudine, or a variation of lamivudine that we refer to as FTC sometimes, but they're very similar. And then the third drug that we would add would come from the NNRTI class, or the non-nucleoside reverse transcriptase inhibitors. And at first, again, those drugs were nevirapine and efavirenz. But we know that the virus becomes resistant to nevirapine and efavirenz very quickly. So what happened over time is, as resistance increased, we knew that children in particular were at high risk for resistance, not just because they were taking their own treatment. And again, as Dr. Abdul mentioned, very often they're dependent on the caregiver. So if a dose is missed, or they have not been taken back to the clinic, or they have not been reweighed to make sure they're on the right dose, it's very likely that resistance had occurred. And so we moved into a phase where we were providing protease inhibitors. And this is the drug that many of us may be familiar with, lopinavir ritonavir. We refer to it as Kaletra. We refer to it as Lopirito. But it's a hard drug for children to take, but it is a drug that was effective. And all of this changed when the new class of drugs was introduced, and those were the integrase inhibitors. So dolutegravir, which was the drug that everybody was looking forward to, as it's easy to take, it has low toxicity, and it's very, very effective. And also, the virus does not become resistant to it as quickly as it became resistant to nevirapine and efavirenz. Next, please. Next. Thank you. So this is really just sharing the evolution of the preferred WHO recommendations for first-line ART over the years for children and for adults, children, adolescents, and adults. And you can see again here our NRTI backbone. We had moved from previously toxic drugs or expensive drugs. We've brought the cost down of the better drugs. We've removed the toxic drugs, and we've progressed towards simplified and less toxic regimens. So from 2018, actually, dolutegravir-based regimens became the preferred regimens for all populations. So this included children over the age of 4 weeks, and that was in conjunction with a NRTI backbone. So for children, it's a bacavir because tenofovir is not approved for use in young children. Next, please. So this is where the challenge comes in. We still have children that need treatment. We have very few children, and this is very different from the adult space, where we have I think something like 40 million people, almost 40 million people on treatment, and the majority of them are adults, and the majority of them can take one tablet, which comprises tenofovir, lamivudine, and dolutegravir, or what we call TLD. So everybody on this call could take that one tablet, and it's appropriate for all of us. Now, in the pediatric space, there are far fewer children. It's a small percentage of all people living with HIV. But as we know, children come in different weights and sizes and developmental levels. So we have to account for all of those variations of age. And for that, we need multiple formulations, because young children cannot swallow one large pill. And an older child may not take, 10 teaspoons of a liquid. So we have to adjust to make sure that the drugs that we're giving to children are appropriate. Next, please. And so here is where we start thinking more carefully about formulation. So I want to, again, just review that when we talk about treatment, we are now, in our paradigm has been to talk about 3 different drugs that are given together. And so each drug we have to consider separately. And as each drug, we have the drug, but it may come in different formulations. So again, I'm going back to Lopirito with the slide, because as many of you remember, we were giving Lopirito syrup, which needed refrigeration and was cold, refrigeration and was sort of very difficult to tolerate. But then we moved into not only tablets for older children, but also these pellets or these granules. Sometimes we call them the sprinkles. But again, these were not optimal because they were still difficult to take. But this is an example of how one drug can be formulated in different ways to make sure that the drug is being given appropriately to a child. Next slide, please. And so here we are. This is actually an older slide. This is from 4 years ago. And we have over 70 different formulations of pediatric drugs that are appropriate for children, but not all of them are made anymore, because many of these, you can see on the, it's very small writing, but some of us may remember there was the drug DDI, which was a very toxic drug. And again, I mentioned stavudine or D4T, which was a toxic drug. So we no longer use those. And as a result, manufacturers have slowed down or have stopped even making them. Next slide, please. And so this is where we also think about supply chain management, how we think about the supply availability of pediatric formulations. And again, remember that when we're managing the supply, it starts with the drug being made by the manufacturer, and then it has to be shipped or sent to the program that has ordered it, and then it has to be distributed to each clinic where there are children who need it. And not all clinics now have children, because again, we have done a great job of scaling up treatment for pregnant women, so there are far fewer children. And then this has to be used effectively, given to the right clients at the right dose. And then when that stock gets low in the facility, it has to be reordered in time. And so there's a whole cycle that happens that helps us to make sure that drugs are there for the right client in the right place at the right time and at the right dose as well. Next, please. And this is the challenge that we have been facing, which is basically that when we talk about the pediatric ARV market, what we're saying is we need to make sure that there is a sustainable supply, and there is concern that over time, as fewer and fewer children younger children need treatment, there will be less and less interest from manufacturers in producing these drugs. So for example, we are trying to keep the cost of drugs low. So we often, our programs are purchasing drugs or procuring drugs from generic companies, which are trying to keep their drug prices low. And the way they do that is they sell at scale. So they will make, for example, 10,000 packs of one product, and but they'll wait until, to make that 10,000, they'll have to wait until they have 10 orders for 10,000 packs. If one country orders 5,000 packs, they'll wait until another country orders another 5,000. And so one of the things that has happened and has used to happen in the past was, when we had so many different formulations, the manufacturers would wait until the orders accumulated so that they would start making it. And that resulted in significant delays and stockouts. And this is really the problem with pediatric drugs. We know there's a problem somewhere in the supply chain when there's a stockout. And this is what we're trying to prevent from happening. Next, please. So this is where pediatric ALD comes in. And we now, after many, many years, have harmonization of the drugs that allow for harmonization of treatment across populations. And the adult standard of care has been 1 tablet per day per person for years, since TLE, tenofovir, lamivudine, and efavirenz, which we have almost stopped using entirely now, or stopped recommending, because again, we know that TLD is a more durable replacement and does not develop resistance as quickly. So we also now have evidence showing that some of the adult dosing that we use can be used in younger children. Again, we think about the pediatric population being everyone under the age of 15, but within that, we have to think about infants, young children, and young adolescents. And so one thing that happened is, for children under the weight of 30 kilos, we now know that we can use TLD, which is an adult formulation, safely. And then we also have evidence showing that the 50 milligram dolutegravir tablet, which is the one drug, can also be given to children weighing 20 kilos or more. And that's about a 7 or 8-year-old child. So the point here is, as many of our children are now getting older, a lot of them are actually now on adult formulations of drugs. But we still needed something for the youngest. And this is where generic 10 milligram dolutegravir became available. But again, that was a single drug that needed to be combined with a separate abacavir 3TC backbone. And that's the reason why we have two different products that are needed for younger children until we have PALD, which combine the dolutegravir and the abacavir 3TC into one tablet. Now, this makes it more convenient because caregivers really only have to now have one bottle, store one bottle, but it also makes it easier from the supply chain standpoint. There have been a few analyses done about how much it will cost to send two bottles to ship and store and distribute two bottles versus one bottle, and the cost savings is actually quite significant. So this is something that I think we're really encouraging, because we know that having simpler products or having fewer streamlines the supply chain and makes it more likely that we can appropriately predict how much we'll need, but we'll also be able to more easily make sure that it is there when it's needed. And so I hope that that gives at least a little bit of a background about how WHO and how our recommendations have evolved and why we really are looking at PALD as an optimized product. And hopefully this will continue to be available as we move forward. Next, please. So with that, I just want to, again, close with reminding everyone that we have had a lot of evolution and change over the last 20 years, but we do have more effective and safer regimens that we want, and we want the production of this to be sustainable. Dolutegravir is now the gold standard for adult and pediatric treatment. Scale-up has been rapid, and there is increasing data to sort of demonstrate safety and efficacy. Many of us have seen that in our own programs. So we do have fewer children, but it doesn't mean that those that we still have don't have treatment. We need to make sure they still have treatment. And so at this point, we now have one product that can be used to dose infants and children from 6 kilos onwards until they reach that adult dose. And that transition is starting now, with many countries placing their first orders. And with that, I'm going to end, and I'm looking forward to questions and the discussions. Thank you again for having me.
Great. Thank you so much, Dr. Nandita. And we do value your contribution and your commitment and hard work in the work that you do. And thank you for really taking us through the processes and procedures around how we get to getting new formulations for children, what is required. And because I know sometimes when you are on the other side, probably as communities, we don't get to hear more around what then really happens behind the scenes, the work that needs to be put in, the considerations that need to be put in as to ensure that we have formulations for pediatrics that they can be able to take as well. And also just understanding how the uptake for adults and uptake for children is different in terms of the different medicines also is very much helpful. Thank you for really giving us that wealth of knowledge and also the work that you're doing. Thank you. So moving forward, and please do utilize the Q&A and share your questions, and also even within the chat and share your questions, because the whole purpose of the webinar is for us to really start these conversations around better treatment options for children, knowing what exists, what to look out for. And as Dr. Nandita mentioned, that even some countries right now are already moving towards transition. So this is also just an opportunity to understand that if your country is already talking about transition to PALD, what does this mean? What is PALD? And I think from Dr. Nanita's presentation, she managed to really break down so that we could understand the journey and how medicines for children have actually evolved. So please take this opportunity to be asking questions within the chat and the Q&A so that we can really benefit from the different experts that we have on the webinar. So next up, we're going to welcome Sebastian Morin, who's from the Medicines Patent Pool, who's the Policy and Advocacy Manager. So from 2013 to then, he was a research officer at the International AIDS Society, where he led the work of the Industry Liaison Forum on Pediatric HIV and Regulatory Affairs. He also spearheaded the HIV Co-Infections and Comorbidities Initiative in the areas of HCV and TB. Dr. Marini is author of several publications on pediatric drug formulations, hepatitis C, COVID-19, and people who inject drugs, as well as regulatory affairs and treatment access, in addition to scientific articles originating from his previous basic science research on antibiotic resistance and HIV infection. Dr. Marini holds a PhD in biochemistry from the Laval University in Quebec City, Canada. So, Dr. Marini, welcome to the webinar, and you may take the floor.
Thanks very much. Bonjour tout le monde, bom dia. Hi, everyone. So I work for the Medicines Patent Pool. We are a UN-backed foundation based in Switzerland, in Geneva. I'm also involved in the Global Accelerator for Pediatric Formulations that we also call GAPF, in which is happily co-hosting this webinar today with GNP Plus and PATA. Next slide, please. So I'll cover a few points that have been raised already and perhaps give a bit more substance in terms of the uptake and rollout. But before doing that, I thought I would make sure to mention that I don't have any conflict of interest to disclose, but I'd like to thank all my colleagues at MPP, as well as our funders, Unitate, but also the governments of Switzerland, France, Japan, and Germany, and also all our partners. MPP works in partnership. In particular, in pediatrics, we work with GAPF, and through GAPF, this network that's hosted with WHO, as well as with the many partners, more than 30 organizations. And so here you can see a screenshot of the GAPF strategy as well as the MPP strategy, and these two are synergizing and linking to each other. Next slide, please. So as Nandita was explaining, we've been quite successful rolling out pediatric DTG 10 milligram cold dispersible tablet. So this is the single tablet of dolutegravir, the generic version from 2 suppliers. We've seen supplies go to countries starting in 2021, starting with 10 countries that receive catalytic procurement and then going up quite quickly, as you can see on the right graph, where at the end of the last quarter of this year, so the Q1 of this year, we had supplied 95 countries through the generic manufacturers. This success story has been made possible by contribution of many different partners, and I'd like to mention here CHAI, Penta, Unitate, VIV, WHO, ECPAF, the generic manufacturers, procurement agencies, the funders, and the governments. Next. And so when you look at the map of where access is happening and where access is possible, so supplies and so access to this new product has been possible in 95 countries that are shown in yellow. And the countries that you can see in green are the other countries where access to the generic version is allowed, is possible, but where we haven't seen uptake yet. So these are remaining opportunities for transition to something that's better clinically. Next slide, please. And so here you can see additional information on the rollout of pediatric DTG 10 milligram, the countries that have had most uptake so far, and each bar indicates the amounts that have been supplied to these countries across the 3 years of rollout that we've seen so far. So some countries have started already in 2021 and others have followed. And so right now we have of course, very high coverage in Africa, but also throughout other countries. At the time of rollout, GAPF had been trying to contribute and make sure that information sharing and coordination was facilitated among different partners. And so we created what we call the PDTG task team, and we had published a memo that you can see on the slide here, and the slide has a link where you can access that. Next slide, please. Now, of course, we're looking forward to the rollout of pediatric ALD. So that's the fixed dose combination. So the single tablet that, as Nandita was saying, is bringing us closer to the standard of care for adults. So one type of pill that includes the full regimen, the 3 drugs in a single pill. And so we're encouraging the transition to this new medicine, and we've published a memo also on this topic that includes a decision tree that we can see here on the right of this slide that is all about minimizing wastage. So there was a question in the Q&A about how do we manage the stocks of PDTG and Bacavir lamivudine that we might have as we transition to pediatric ALD. And here there's a very simple decision tree whereby you can align the stocks of different products and make sure that you use both of these before transitioning to the fixed dose combination. And so the idea being about minimizing wastage, but also ensuring that there's a prompt transition that is not delayed, given that this is a more optimal product that can help with adherence and also supply chain. Next slide, please. So we've started seeing some uptake of pediatric ALD, and the map that is shown here shows that there's been a filing in 15 countries. So there's regulatory review that's ongoing in 15 countries. These are the countries shown in dark blue. There's one approval at the national regulatory level in one country, that's the light blue, that's Ghana. And there's one country that has already received supplies, and it's shown in yellow, and it's Zambia. So this is just starting. We've seen the first supplies only in the first quarter of 2024, and we hope to see many more as we move forward. Next slide, please. Yeah, so there's a few concerns though, and that I think that speaks a lot to the slower pace than anticipated that we are seeing. We, of course, would like to see a transition that's prompt and that's not delayed, but there are concerns. There are concerns about wastage that I've mentioned before that can be managed with the decision tree that we've put out. There's concern about transition fatigue. Of course, there's been other transitions before, and so there's been some reaction that, okay, this is another step. We need again to adjust and to move to something else. But we have to remember that transition fatigue should be overcome, and it can be overcome. And when we think about the health of kids and how we can improve the adherence, but also ensure that they get the proper regimen through that single pill that combines the full regimen. And there are concerns around cost, and Nandita said a few words around that. Right now, when you compare the drug cost directly, there's the ALD combined formulation is slightly more expensive, but the supply, the supply chain, the shipping, all of that is going to be less expensive. So this balances out the differences, and over time we'll see also pediatric ALD prices go down, as we've seen with every other ARV really in the past as these were implemented. Next slide, please. And so this is just showing some data from a few months ago of the planning for some countries that were about to transition this year and the next, as viewed by USAID PEPFAR. This is not meant to be quantitative and showing everything and comprehensive. This is meant to show that there is some planning. There are some countries that are moving. I mentioned Zambia before. There's Zimbabwe, and there's also Uganda that you can see very easily on this slide, for example. Next slide. So I'll end with this slide here, just to say that we're talking today about with community, healthcare workers, people at the country level, and it's important to stress that there's a need for advocacy towards non-delaying optimal treatment equity. It's all about equity and having better treatment for kids. Adults have been able to access a 1 pill a day combination therapy for many, many years, but right now, we have the opportunity to do the same with children, so we should do that. So we're offering here a few thoughts around the type of advocacy that could take place from mothers, caregivers, healthcare workers, and treatment advocates to reach out to your governments, ask about the PALD transition plan when they think about updating the guidance, strategy for the switch and the transition of the kids, the timelines, the volumes that are planned, share PLD transition resources. I've shown the PLD brief in a previous slide, and there's a few links at the bottom of the slide with resources to support in-country transition and uptake of this new formulation. Reach out to GAPF and the partners to report any challenges that could be around policy, supply, implementation, share transition plans, so we too can have visibility and support the countries because we know when each country will be transitioning, and also share transition success stories, because that can really help other countries to move forward when they see that peer countries are being successful in that transition. And last, report anything to MPP with regards to the products themselves, including issues with registration, supply, quality, delays, anything. We are available and we're happy to support where possible. Next slide. And so with this, I'd like to simply, next slide, please. Yes, just thank everyone. Thanks for your very important contribution, making access to better pediatric medicines possible. And I'll be happy to answer any question. Thanks very much.
Great. Thank you so much, Dr. Sebastian, for really breaking down issues around also supply chain and also issues around barriers to access and work that is being done in terms of ensuring that we not only cater for better options, but we make sure that these better options are available and accessible for children, as it is a basic right for all children to be able to access. For that valuable insight and contribution and information. And to also the audience, thank you so much also for the very active and active engagement within the Q&A. Let's continue to need answered on this important topic, whether we're working from communities, whether we're working as implementers, at different levels that we're working. Important to ensure that the opportunity of this important webinar and also of the different expertise on our panel. So without further ado, we are going to move on to our next and last speaker, who is Babalwa Mbono, who is the Strategic Project Officer at Mothers to Mothers and also a Global Alliance Champion for South Africa. Babalwa has over 15 years experience and has trained local women living with HIV to work as community health workers, known as mentor mothers. These mentor mothers provide their health services, education, and support on HIV and other critical health issues to pregnant women, new mothers, children, and families in under-resourced communities. As one of the Mothers to Mothers first mentors, Babalwa fully understands the challenges faced by women and families in sub-Saharan Africa. She was diagnosed with HIV at the height of the pandemic in South Africa 2 decades ago and has since dedicated her life to advocating for policy change on community healthcare work and universal health coverage. So we welcome you, Babalwa, to the webinar, and please do share the insights and expertise that you have for us today.
Thank you so much. Thank you. Good morning, good afternoon to my colleagues. Pleased to be part of this session today. I'm looking forward to hear more and sharing of experiences, and also with the work that I'm doing as a community advocate for Global Alliance to End AIDS in South Africa. I'm going to start with the priorities, as we know that this is a challenge that we're all experiencing, as I'm hearing my colleague from Nigeria. He is also sharing the experiences based on his country. I can see there are commonalities in terms of how we are able to support and the challenges that children and caregivers are experiencing. As South Africa, we have some priorities that we have put together as our action plan that will help us to reach our goal of ending AIDS by 2020 on children. One of those is to strengthen case findings among HIV-exposed infants and children, to scale up initiation of DTG-based regimen to pregnant and breastfeeding women as per the revised guidelines in the country, to strengthen regular retesting of pregnant and breastfeeding women, to scale up access to social protection, which is your social grants, nutritional support, early childhood development for eligible children, adolescents, women living with HIV, and key priority population for improved access to HIV treatment and services. The last one is to address gender-based violence, femicide, sexual assault, and abuse for infants, children, adolescents, and women. These also include the scaling up advocacy for enforcement of laws. Next slide. When we look at the priorities, we have to go back and look at how the country is performing on children. When you look at our 95 HIV treatment cascade under 15 years, as of March 2024, we have 82% of children that know their HIV status. 63% of those children have been initiated on ART. From those that have initiated on ART, we have only 42% that are virally suppressed, which is under 50 copies. So this is a big challenge for us, and it's concerning for us as the advocates in the country. What we have realized is that these children receive this, some of these children receive the services from the public and the private sector. From these children, we have realized that 3,861 of them, those that are under 15, received their antiretrovirals through the private sector. Then children from 5 to 18 years who are virally suppressed under 50 copies or milliliters are eligible for differentiated models of care, which now we are trying to provide space and also opportunity for them not to go every time to the clinic so that they get tired and not want to go back to the facilities. So those that are adhering well with viral suppression, we decant them or they are given multi-month treatment. This is not enough looking at the target that we have to achieve by 2030. So we have taken up a stance as a country to increase antiretrovirals initiation for children under 15 years, and also to ensure that those children who are initiated are maintained in the correct treatment regimen and with the suppressed viral load. Next slide. So we have to sit down and look at the children that are not on treatment so that we're able to trace and find and trace those children and find them and retain them to care and test them so that we're able to leave no child behind. Based on the age distribution, we have noted that children, we have got 7.3%, sorry, it's not clear there. We have children 7.3% under 4 years who are not on treatment, whom have not been even tested, who don't know their HIV status. 14% of those children are from between 5 to 9 years. 23.4% between 10 to 14 years also don't know their HIV status. And you can see the majority of our children in the country between 15 to 19 years are 55.3%. This has raised a concern to us. Next slide. This now has led us to put together this plan to advocate to ensure that all these children are tracked and children are put on TTG regimen as our priority action plan, as I've presented in the first slide. What we have done, we ensure that for treatment literacy, we ensure that it is incorporated in the development of provincial and district implementation plans for HIV, TB, and STIs for the new strategic plan 2023 to 2028. Also, we are supporting and facilitating the launch and the implementation of U equals to U campaign in provinces. We are also working with multi-stakeholders in developing IEC materials for primary caregivers on HIV testing, giving consent, linkage to care for antiretrovirals, and treatment literacy. We are also extending our messaging in terms of using other platforms or extending information from the existing platforms that we are using in the country, like your Mom Connect platform, where is a platform we use where people or women that are pregnant and breastfeeding or postnatal receive health promoting messages, auto messages from SMS, or can be on a WhatsApp. We are looking at extending those services to HIV caregivers living with HIV, and for children living with HIV, so that they are able to be supported. Also, we are looking to expand on site-to-site campaign to extend that campaign, where we are promoting nurturing in care of children, where we provide information, messages on the Road to Health card. We are going to extend that as well to add all treatment literacy information. We are looking at providing awareness campaigns in communities and at facility level. So for community advocacy, how we're going to strengthen that to ensure that all the children that we have been traced are also monitored and supported. We are going to strengthen index testing in antenatal and postnatal services through HIV self-screening for partners, index testing for children and their siblings. We are also going to work with the Department of Education, Basic Education, which is Ministry of Education, to ensure HIV consent form component is aligned with the integrated school health package of services. We are also working with other stakeholders to drive a campaign message of Know Your Child HIV status, which will be aligned with the National Health Calendar, and also to implement LIFT project at PEPFAR District. Again, we are looking at establishing and support community-based HIV/TB screening and testing, including follow-up on services that are provided by community health workers in the communities, and also the implementation of the community antiretroviral SOP for children and adolescents. What do we mean when we say this? We mean that these community health workers, when they go into these households, we are extending the services in ensuring that as they engage with the people in the household, if there are children that are taking antiretrovirals, they will engage with them in understanding the treatment that they are taking. If the caregiver understands the treatment, the adherence issues, viral load monitoring, provide education and support, and referral if there are any challenges that these children are experiencing, which the caregivers don't understand. Also, we want to strengthen learner support programs at schools to identify and refer learners in need of additional services. And again, we are looking at capacitating and update and provide updates to learner support agents. This one, we are going to work with the Ministry of Education as well. We are also looking to support and implement the integrated scheduled visit, which will be aligned with the patient antenatal care, antiretrovirals visit, contraceptive visits, immunization, and other care of caregivers' child visits. Also, we want to implement the postnatal care ideal clinic. Currently, we do have antenatal care ideal clinic. We want also to extend that service to ensure that all services are provided on postnatal care that are needed for the patient, and for us to be able to track and follow up all these services that we are providing to children living with HIV, youth zones and care, and youth care clubs for adolescents and young women. Thank you. Thank you for the opportunity. I'm looking forward to questions and comments. Thank you.
Thank you so much, Babalwa, from that informative presentation, and also really taking us back in terms of the advocacy work that we're doing, show that children that are not on treatment get on treatment. Children are found, and we're able to ensure follow-up mechanisms for children, as well as supporting children at the facility as well as communities. And thank you so much for sharing some of the key the key priorities around advocacy within your work, and also within the Global Alliance work. So, ladies and gentlemen, those were our speakers for the webinar this afternoon. And before I just leave over to our co-collaborator, Pata, to take us through the Q&A question, I just want to take this opportunity just to thank you all panelists who managed to bring in a wealth of experience in terms of making sure that our children have access to better options in terms of medication. Thank you for bringing really a light and insight around some of the key barriers that exist and how we can overcome them as countries, and also through our advocacy work, and also how your organizations are also committed in terms of addressing that. Thank you also for bringing in perspectives and all around the facilities, and also the interperson conversations that are happening with the different clients as well as children at community level, and also really giving us that backdrop and that background around how we get to new and better formulations for children, the amount of work and the amount of data and information that is required, and certain considerations that are required, which all in turn help us be able to develop better key advocacy messaging, and also really improve our efforts and our work around ending pediatric AIDS in children. So at this particular time, I just want to hand over to Luwen, just to take us through the question and answer. Please do stay on such that we're able to continue to gain as much as we can from this. Lu, over to you.
Great. Thanks so much, Anna. And yeah, just wonderful. Great to see all the questions. If okay with everyone, we're going to just extend the webinar by 10, maximum 15 minutes, just so that we could have a little bit of Q&A. But just to let everybody know that this collaboration between GMP, PATA, and GAP-F, this is just one of several webinars, so keep watching the space. We're going to keep on sharing information and making sure that, you know, closing the treatment gap for children, we are able to share much more in this space so that we can have more engagement with community and frontline providers. So this is just the first of several webinars and some other exciting collaborations. So you will be hearing from us. But just, I wanted to pose one or two questions to each of the presenters, if that's okay. So I'm just going to pose one or two questions and then ask each of the presenters to answer that question. Apologize if I haven't captured all of the questions. But Dr. Fofi, one question to you. I know that you answered it, so just answer it in short live when we get to you, is around this question whether advanced HIV disease is more present in children, and why is it particularly difficult to manage or treat? So if you could focus on that question. And then Nandita, lots of questions for you. One, I mean, just if we stick to PLD, some questions around formulation. Is it only a tablet form? Could you speak a little to dosing adjustment by weight? There was one question around under 3 kilograms. And then there was a particular question around TLD resistance. So if you could touch on that. And then Sebastian, I know that you addressed the sort of questions around the complexity of stock. So people are sort of asking again, maybe just if you could stress the sort of decision-making framework, but DTG 10 milligrams, 50 milligrams, when people still have loads of stock, what's the planning, how to manage that? And then, I mean, a very specific sort of health system question, which, yeah, I mean, I can imagine for, I think some of the examples shared in Nigeria where we still, you know, need dosing by weight, and many of our clinics actually don't have the most basic infrastructure like scales. So sometimes, yeah, these realities, yeah, on the ground are challenging. And then let me just see if I've covered all of them. And then Babawa, yeah, you gave such great examples just in terms of South Africa sort of mobilizing community, creating awareness, creating demand. I think so important. Just one of the, out of all your experience, what are one of the strategies I think you could share, especially for many of the other frontline providers on the call, in reaching caregivers and making sure that we can promote sort of treatment literacy and understanding amongst the community and caregivers to be able to create more demand? Just your own personal experience, what for you has worked most in getting caregivers and communities most engaged? So if you could answer that question. So Dr. Fofi, over to you.
Thank you very much. Just to give it a perspective, I would say that according to WHO, advanced HIV disease can be defined as anybody with HIV with CD4 cell count of less than 200 cells per microliter, and for children less than every child less than 5 years old should be considered as advanced HIV disease, except they are 2 years 2 years and above, and they have been stable on medication for more than a year. So with that definition, you see that majority of children, especially less than 5 years old, they are already AHD, because owing majorly to their immune system, immature immune system, and because the disease in children, especially less than 2 years old, is quite rapid, you know, and it's quite with that, it makes it number one, for those above 5 years old, you know, we have high risks of opportunistic infection coming down with high risks of opportunistic infections, making it more difficult and complex because the child will now have to have repeated hospital admissions, you know, out of school, you know, a burden to the caregiver, you know, greater P burden, making it difficult for the child to take their ARVs. You know, all that makes it a bit complex to manage children with AHD. So thank you very much.
Thanks very much. Thank you so much. And Nandita, if we could go to you, thanks.
Sure, thanks. And I saw there were a few questions around dosing, as well as questions around what to do with the extra stock. I'm going to speak to that, though I know Sebastian will probably have more detail on this. Just in terms of dosing, I want to go back to, you know, PALD is 3 different drugs, and each drug is actually recommended at a certain dose by weight, based on weight. And the way this tablet was developed, so that it is 30 milligrams of abacavir, 60 milligrams of lamivudine, and 5 milligrams of dolutegravir, was designed so that it could be given, the dose could be adjusted by giving different multiples of the tablet. So for a smaller child, you'd maybe give 1 tablet. For a bigger child, you would give 3 tablets, but they would still just need that 1 bottle. And so that's actually, you know, again, the supply chain here is critical, and that is what helps us to make sure that the drugs are there when we need them or when the clients come to collect them. And I'm a little troubled that there are, facilities that are providing pediatric treatment without a scale, because weight is how we make a decision about what the dosing should be. So I just want to stress how important that is, and that's one of the reasons why when we speak about advanced HIV disease, as Dr. Abdul Rahman was just reminding us, that all children under 5 are sort of labeled as having advanced HIV disease, and that's partly because they present late, as we've heard, like we're not finding them early enough before they get sick, but also because we know that they have to change their dose as they grow. So that's one of the reasons why they do need to come back to the facility when they're younger and growing fast. As they get older, they don't have to come back as early. So that was some of the thinking behind, why we need to think about younger children a little bit differently. Now, there's another couple questions around the dosing and what to do with those children who are under 6 kilos or under 3 kilos. And so I will say that currently PALD is not recommended for use in children less than 6 kilos, partly because we're not sure if that ratio is sufficient. And we don't want to give too low a dosage, because that could lead to drug resistance down the line. And so we want to make sure that we're giving the appropriate dose, and we're not sure that combination has the right dose for those youngest infants. Now, there are very few of them, but those few infants will still need to be dosed with dolutegravir 10 milligrams combined with the separate abacavir 3TC 120 60 milligrams. So those 2 tablets will still be needed for those very few infants, but as they reach 6 kilos, then we will be able to transition them into that PALD. Many countries do have sort of stocks of pediatric 10 milligrams as well as the separate abacavir 3TC. Now, these are drugs that are the same drugs that are contained in PALD, but they're just separate. And so that does create bulk and distribution and so forth, but they're the same drugs essentially. So they can still be used. And I think there are programs who are considering how do we balance, how do we make sure that we're not wasting drugs that are perfectly good because a new product has come along? And the answer to that is twofold. And I think Sebastian will go into this in more detail, but it's really understanding who your pediatric patients are that you're and that comes from the data that comes from health facilities. So it's important to look at the numbers of children and figure out, and this is something that globally we see programs are getting much better at. So this kind of information that we get from countries that, we have 6 months left of PDTG 10 milligrams, and we have 3 months left of abacavir 3. We used to not even have that information to be able to balance, but now we have more visibility into what is available, and this will happen over time. So countries are placing orders, and as time goes on, those older stocks will be consumed and the newer products will come in. And that's what we're looking at, is over time, the whole system will be transitioning to something that is simpler and more sustainable. And this is something that's going to happen. Whether it happened, and I think the decision that has to be made is, are we all going to be very coordinated and understanding and balancing, or are we going to do this in an uncoordinated way, which we've seen in transitions before? Some of our past transitions have been challenging because we don't have visibility, or we don't have a strong supply chain all the time, and we frequently experience stockouts. So stockouts are actually a really good sign that something is wrong there that we need to investigate. And if anything, I think that is something that we do need to understand more of. How do we better predict how many pediatric formulations will be needed at any given point at a time? And as we have fewer children, that becomes more difficult. So this is not to say that PALD is coming and replacing everything. It's coming as a way, as a form of the currently recommended regimen that is going to be more sustainable and easier for programs to manage, but also easier for caregivers and infants to to both, you know, carry around, to store, to take. And so this is the change that's happening. But again, it's not perfect in that we're always still trying to make sure that every child has access to the safest, most effective regimens. PALD right now is not, we don't have the data to look at under 6 kilos, and hopefully we will have that. But that again, if we see it, because younger children metabolize drugs differently, the dosing can change. So it's not a very easy calculation to always make. So those are some of the considerations that go into what these recommendations for which formulation to use.
Thanks, Nandita. I think if there's the question around TLD resistance, I wonder if you could maybe just type that. But
Sure.
I've made a note of that, and maybe in our next webinar series, we can do something more around sort of resistance and areas around that. I'm just worried about time. So I want to hand over to Sebastian, and then we're going to give Babawa the last word. Over to you, Sebastian.
Yes, thanks very much. Nandita covered most of the points very well, but I just want to stress that the idea of this decision tree that we've included in the memo is actually coming from USAID PEPFAR initially, their global health supply chain management system. And it's all about matching the quantities of drugs that you have right now, so that when you transition, you're not left with a single of something that's not so useful anymore. That said, of course, there's this weight band that's very low where there will be a need for the single still. And in the case of boosting for tuberculosis, which is also something that will use some of the 10 milligrams. On the health system challenges, I think that's you know, the reality of the body of children changing over time is not something we can address with drugs. We have to adjust the dose, and that's based on weight. And so that's unfortunately something that we cannot bypass. But I think that's a very big place for advocacy. If there's no scale in some clinics, I think this can be solved in a straightforward manner. And just last thing is, we are available. And when I say we, I talk about everyone here, everyone on the GAPF network, our PDTG task team, which groups all the organizations or the main organizations involved in transitioning to dolutegravir and now to ALD. You can reach out, and we can then assess any issues that is emerging and offer guidance, and as we've done in the past with these memos. So please be in touch. And thanks very much for covering this topic today.
Great, thanks, Sebastian, and really appreciate that, and look forward to having you part of this ongoing series of webinars. Babawa, I'm going to give you the sort of last word to give us the sort of magic bullet in terms of how we really mobilize communities, create awareness and demand, and just speak from your own experience here in South Africa. You know, what you could share with some others in the many other countries that have joined our webinar today. Thanks.
Thank you for the opportunity. I would say the important thing is to ensure that we work with other stakeholders. We cannot fight this alone as Department of Health, as advocates. We need to work with other stakeholders that include social development, which is your social welfare ministries, your Department of Health Education, where we get these children where they are most of the time. So I think for me, a collaboration and integrated effort will be able to assist us to combat this and end this. Again, the other thing that I would share on antenatal, on maternal, postnatal care, we used to have postnatal clubs, which I think we can look at them in terms of bringing the women and caregivers and those children living with HIV, because currently we have this postnatal clubs for only children and exposed children. Now we can look at that, maybe bringing in when the woman comes for their antiretrovirals scheduled appointment, the baby also will have the same date, those integrated scheduled visits. whereby they will be sitting together, where they'll be able to share experiencing, learning, and someone, maybe health promoters or community health workers that are within the facility can also give that education. And when you strengthen more on community awareness programs and campaigns in the community, whereby you'll be able to track and get these children and test them at the community level, where we'll be able to refer them for further assessment and clinical examination in the clinics. So I think those are the critical one for me. And the last one is a peer model approach. I know it's difficult to talk about this because some instances we don't have more funds or resources to implement these projects, but with current implementing partners, I would like them to think of having peer model approach, where we now will have a consolidated peer model approach. We'll talk to pregnant, breastfeeding, and children living with HIV, which cannot be left behind. I think those are my closing remarks. Thank you so much.
Great, wonderful. I think absolutely you ended it well, as in leaving no child behind. Sarita, I just want to extend a huge thanks to all of our wonderful, wonderful speakers, also to GMP and GAP-F, and, you know, we're going to keep this space on fire. And keep engaged. So please, we will be in touch and we will continue this conversation. If you have any sort of very specific thoughts, ideas on topics that you'd like, please do share that with us. And we're going to just keep growing this community, frontline community of caregivers as well as frontline providers. So huge thanks to all of our speakers. And as Pata says, we do it right, we do it together, and we do it now. So thanks, everyone. Look forward to chatting soon. And thanks just for taking time out of your day. And I think the recording and the presentations and everything will also be shared with everyone. So huge appreciation. Thanks to all our amazing speakers. You haven't seen the last of us. We'll see you again soon. So yeah, have a great day and thanks everybody.
Thank you, everyone.
Thanks very much. Goodbye.
Thank you.
Thank
Cheers.
you.